Born to care for others, for whom health is much more than a job. It's a vocation. It's their life. Let's take care of them very well. Let's take care of them all together. Nestle Health Science. Who takes care of those who take care of us? Who takes care of those who devote their whole life to take
مساء الخير على حضراتكم. Good evening everyone. I'm Ahmed Faltas, Category Business Manager responsible for Anglophone countries in Africa for Nestle Health Science. And it's my pleasure to be with you today. And first of all, let me start by just saying what employees in Nestle Health Science are passionate about. And really, this is about empowering healthier life through nutrition, with a clear vision of providing premium quality, science-based and nutritional health solutions to enable patients and the healthcare providers as well to live healthier lives. And on behalf of Nestle Health Science team, I would like to welcome all participants from Egypt, Arabic and African countries. It's our pleasure to be with you today in such a unique scientific gathering. And good to mention here that one of the new concepts of continuous medical education is sharing experience. And that's why this respected group of audience from different countries will enrich this meeting more and more. And for today's agenda, we are lucky to have a group of great speakers from Ain Shams University, which is for more than 70 years have a very strong impact on spreading the science and knowledge, not only within Egypt, but also across the whole region. Our speakers today will be mainly talking about malnutrition in pediatric critical care. And as you might know, nearly 1/3 of children globally suffers from at least one form of malnutrition. And for sure, this percent is a bit higher in our countries. That put a great responsibility on our shoulders to raise awareness and shifting the community thinking from just the concept of food security to the concept of nutrition security. It's not just the quantity of food that we are providing, but also the quality of food, which is more important for sure. And now, and without any further ado, let me start by introducing our today's speaker, from Ain Shams University, and it's my personal and our department pleasure to have Professor Mustafa Al-Hodhod, Professor of Pediatric in Ain Shams University and the head of Department of Pediatric Department in Ain Shams University, and our today's moderator, Professor Yasmin Gamal, Director of Children's Hospitals, Professor Ihab Khairi, Head of Nutritional Department, and Professor Hanan Ibrahim, Head of PICU Department, Professor Ahmed Hamdi, Head of GIT Department, Professor Iman Foda, Head of Pulmonology Department, and Professor Omneir Rashidi, representing Neurology Department, and last but not least, Professor Muhammad Hisham, representing Pediatric Surgery Department. Please share me to welcome them all and have a nice webinar. And now I will leave the floor to Professor Mustafa Al-Hodhod to start the meeting.
Assalamu alaikum. Dear pediatricians all over Egypt, in Africa and Middle East and Arab countries, you are welcome to this heavy meal of science in pediatric malnutrition, pediatric critical and special care. And I introduce here a group of stars from pediatric department of the great Faculty of Medicine at Ain Shams University. And by the end of this session, I think you'll appreciate both the science and the team working and how much persons can answer questions that are urging in the mind of practicing pediatricians. We are having here different specialties of pediatrics to answer these questions. Professor Ihab Khairi, Professor Hanan Ibrahim, Professor Iman Fouda, Professor Omneir Rashidi, Professor Ahmed Hamdi, and Professor Muhammad Hisham from pediatric surgery. And actually, the problem of malnutrition in Egypt and all over the world is forming a critical and challenging issue for all the scientific committees all over the world. Please keep aroused and keep attentive all through this activity, and we hope to hear from you, your comments and your questions. Thank you, Dr. Ahmed, for preparing this meeting, and thanks for Nestle Health Science for all the participation in the continued medical education. Thank you.
Good evening. Good evening, dear participants. I have the pleasure to be amongst you today and amongst my dear professors in sharing with you Ain Sham's experience in using peptide-based formula, Peptamen Junior in different specialties. This will be an interactive sessions where we will be discussing 6 multidisciplinary, 6 specialty, and the use of Peptamen or peptide-based formula in different critical care and special situations in pediatrics. It's an honor to be among my professors, and it's an honor to present Professor Ihab Khairi, Head of Clinical Nutrition Unit, Ain Shams University, giving us a nutritional background in nutritional support in sick children. Professor Ihab.
Hello, good evening, everybody. I hope all of you are feeling well. It's my pleasure and my honor to be with you today in this scientific session for Egypt, Africa, and the Middle East about the experience of Ain Shams University Children's Hospital with the peptide-based formula Peptamen Junior. Thank you, Dr. Ahmed, Dr. Samuel, and the team of Nestle Health Science for giving me the honor to be with you today. Thank you, my colleagues and my dear professors, Dr. Mustafa, Dr. Hanan, Dr. Iman, Dr. Ahmed, Dr. Omnia, Dr. Muhammad Hisham, and Dr. Yasmin Gamal. I'll give you introduction about the nutritional support in sick children, and then different specialties will share us our experience and their experience about the use of peptide-based formula Peptamen Junior in different situations. First of all, I'll discuss with you the causes, prevalence, and consequences of malnutrition in sick children, and the nutritional intervention in sick children, and what is the enteral nutrition, and finally I'll discuss the benefits and uses of peptide-based formula. As we all know, malnutrition is defined as the cellular imbalance between the supply of nutrients and energy on one hand and the body demand for them to ensure growth and maintenance of specific functions. So if there is any imbalance between the intake of nutrients and energy and the demands of the body, which needs this energy and nutrients for growth and maintenance of functions of different systems, there will be malnutrition. Here, as we can see, the sick patients who have illness, different illnesses, whatever, gastrointestinal, pulmonary, or cardiovascular, or neurological disorders, these patients may have acute conditions like infections, trauma, or burn, or organic chronic conditions like cystic fibrosis, chronic pulmonary disease, cancer, inflammatory bowel disease, and so on. In these situations, there will be effect on intake of different nutrients, as all these conditions may lead to anorexia, whether due to electrolyte imbalance, the disease itself, toxemia, some drugs, or some neurological problems may even lead to defect in swallowing and suckling, and so will lead to deficient intake of different nutrients. On the other hand, all these illnesses can lead to different metabolic problems, and this will lead to hypercatabolic state, and sometimes vomiting and diarrhea with marked nutrient loss. And many of these disorders will lead to gastrointestinal dysfunction with maldigestion and malabsorption. This malabsorption, nutrient loss, and hypercatabolism will lead to increased nutrient requirements. In the presence of deficient intake will result in malnutrition, either in defective or negative energy balance, or both the energy and the protein balance, and sometimes associated also with micronutrient deficiency. As we can see, sick children who are at risk to develop malnutrition include three groups of patients: patients with impaired gastrointestinal function. These are patients with malabsorption syndromes due to different problems like cystic fibrosis, inflammatory bowel, short bowel, enteritis, whatever radiation enteritis, chemotherapy enteritis, or any other problem, biliary atresia, pancreatic insufficiency. And the other group is the patients with high nutrient needs, like patients with polytrauma, burn, sepsis, chronic cardiac or hepatic or renal disorders, inborn errors of metabolism, and malignancy. And sometimes feeding problems, and the most famous cause of feeding problems, which is disease related, is the neurological problems that lead to suckling, swallowing dysfunction, and defect in swallowing, like cerebral palsy and coma, and sometimes congenital abnormalities in the GIT. All these problems will lead to inadequate calorie and protein intake. The problem is very famous because 1 in 5 children admitted to hospitals has acute or chronic malnutrition, and about 65% of children who are admitted to hospital due to different diseases, they will lose weight during their hospital stay, even if they are well nourished on admission. And as we can see, disease-associated malnutrition in children give bad prognosis. They will lead to prolonged hospital stay, increased incidence of complications, and reduced quality of life. This was a study done on more than 2,500 patients aged from 1 month to 18 years. What are the goals of nutritional support in sick patients? When we are facing sick patient, whatever its cause, now, what are our goals? First goal is to provide energy and nutrients sufficient to maintain optimal growth, sufficient to obtain normal neuromotor development, and sufficient to improve immune and muscle function and lead to more rapid recovery, thus lead to shortening of hospital stay, and to decrease the morbidities and the complications. This is the first goal, is to give nutrients that support the patients to maintain or to improve all these problems. At the same time, sometimes the nutritional goal may be treatment. Sometimes the nutritional support is the whole treatment of the disease, like in cases of Crohn's disease and food allergy in infants, when we can use elemental diet. The nutritional intervention in sick patient will depend on the age of the patient, the clinical picture, and the possibility of oral intake. Sure, oral to give the nutrition orally is the best, but sometimes you can lead to the use of nasogastric tube or gastrostomy or jejunostomy tube. Also, it will depend on the absorptive and digestive capacity of the GIT and on the dietary habits and the cost. Remember, the cost is very important point in choosing the nutritional intervention in sick patient. Now, if the patient can take oral food, to get the children eat more without unnecessary restriction is the simplest, cheapest, safest nutritional support. It is the best, go without saying, it is the best to give oral nutrition. But if this is not enough to maintain the nutrient need. At this time, we can provide oral nutritional supplements, and the oral nutritional supplements are present in the market. These are whole protein-based pediatric formulas with nice flavors, with fibers, and they are energy enriched to give 1 to 1.5 kilocalorie per milliliter. This is for to give the required energy. But if we cannot give oral food, at this time, we can use a specialized nutrition support, whether enteral nutrition or parenteral nutrition. I'll discuss enteral nutrition now, and we can use only parenteral nutrition, which is not my topic today, only if we have marked defect in the intestinal function, or there is hypermetabolic state with poor tolerance to the enteral feeding, and sometimes you can use it as a supplement to enteral nutrition. But we prefer enteral nutrition more than parenteral nutrition. Enteral nutrition means provision of the nutrients via the gastrointestinal tract, to put the nutrient in the gastrointestinal tract, whether to put it by tube to the stomach or transpyloric to the jejunum or duodenum, or we can use stoma from outside by surgical procedure to give gastrostomy or jejunostomy tube. What are the benefits of enteral feeding? So simply, it's more physiologic. It is the usual rule for nutrition. It will lead to improvement of gut function and morphology. So it will stimulate and maintain gastrointestinal mucosa, will maintain peristalsis and blood flow, will limit bacterial translocation and sepsis, will decrease the multi-organ failure, improve hepatic function, support gut-associated lymphoid tissue and immune function, and definitely it is less costly than parenteral nutrition. The gut, use the gut whenever possible and as much as possible. And a lot of studies found that early enteral nutrition within 24 to 48 hours of admission is usually associated with large reduction in infection and mortality in admitted patients. The only contraindications for enteral feeding is the presence of intestinal perforation and intestinal obstruction, mechanical or paralytic ileus, major intra-abdominal sepsis, and the presence of necrotizing enterocolitis. Now, how to select the formula for enteral feeding? We have certain criteria to select the formula. First, we should consider the nutritional requirements according to the age. We should consider the functional state of gastrointestinal tract, the digestion and absorption capability, a site and route of delivery, the specific needs, metabolic needs of the child, the formula features, and the presence of any food intolerance or allergy. This table is very important, will differentiate the different formula used in enteral nutrition. We have the polymeric formula, the peptide-based formula, semi-elemental, and the only peptide-based formula in our market is the Peptamen Junior, and the elemental formula. Polymeric formula is whole protein formula, while peptide-based formula like Peptamen is small peptides, di and tripeptides. It is hydrolyzed protein, and the elemental, it's amino acid formula. The carbohydrate is glucose polymers in polymeric formula. It is oligosaccharide and glucose in elemental and peptide-based formula. The fat is long-chain polyunsaturated, long-chain triglyceride in polymeric formula, mix of long-chain triglyceride and medium-chain triglyceride in peptide-based and elemental formula. Osmolarity is very high in elemental formula because multiple small amino acids present. The polymeric formula can be used in the presence of normal gastrointestinal tract, normal digestion and function, and they are high caloric and palatable and cheap. But peptide-based formula can be used, it's more expensive, but can be used in the presence of limited digestive capacity due to any problems that lead to maldigestion and malabsorption, like many sick children with systemic or gastrointestinal disorders. And regarding elemental is very expensive and it's a bad taste and hyperosmolar, and it is only used in the presence of food allergy or in cases of severe dysfunction of the gastrointestinal tract, but it's mainly for food allergy. Now I'll talk in the coming few minutes about peptide-based formula. Peptide-based formula, like Peptamen Junior, it's a complete peptide-based formula designed to deliver nutritional benefits to the fragile and difficult to feed pediatric patients between the age of 1 to 10 years. Peptide-based formula carry four main functions, four main properties. It will lead to tolerance, support the tolerance by easy digestion and absorption. It will maintain and enhance gut structure and function, so maintain gut integrity. They will lead to they will support nitrogen retention and utilization and lead to anabolism and will support the body defense. We will see the four items now. Peptide-based formula, how it can support feeding tolerance. It is 100% whey-based. There is no casein. It is 100% whey-based to facilitate gastric emptying. The facilitation of gastric emptying will lead to reduced gastric residue and lower risk of reflux, aspiration, and pneumonia, with lower risk. Also, the osmolarity of peptide-based formula is low osmolarity, and this will lead to reduction in the incidence of diarrhea. This is a study done to compare whey-based formula with casein-based formula in patients with burn. They found that the whey-based formula will lead to 50% less time to reach the feeding goal, 75% less incidence of diarrhea, 32% less event of gastric residuals than the casein-based formula, so it will give better tolerance. Another study in patients with spastic quadriplegic cerebral palsy, they found that there is significantly lower residual volume in patients using whey-based formula than those using casein predominant formula. So they will lead to faster gastric emptying and less residual, and so will decrease the reflux. The peptide-based formula also will enhance absorption. Why? Because proteins are hydrolyzed. Whey protein will be hydrolyzed to tri and dipeptides to ease digestion, and at the same time, generous level of medium chain triglycerides. About 70% of lipids is medium chain triglyceride, and this will enhance absorption. As we know, medium chain triglyceride will lead to rapid gastric emptying, no need for pancreatic enzymes or bile or micelle formation for absorption. They are absorbed directly to the liver without need of to the lymph. Also, they pass to the mitochondria to act as a source of energy without the need of transporter. So medium chain triglyceride will optimize fat absorption, facilitate gastric emptying, and will be a source of energy, and this will lead to protein sparing effect. At the same time, the peptide-based formula has balanced peptide profile, and this will help absorption. How it will help absorption? As we know, amino acids are absorbed in the upper part of the jejunum and needs amino acid carrier. Each carrier will lead to absorption of one amino acid only. And at the time of presence of gastrointestinal dysfunction due to any disorder, the amino acid carriers will be defective. And so the amino acid absorption will be decreased. And this decrease will lead to defect in blood flow and in the integrity of the mucosa. While peptide is absorbed across the jejunum and ileum by peptide carrier, and peptide carrier will carry di and tripeptide with 2 or 3 amino acids absorption, and these carriers are not affected in severe gastrointestinal defect and damage, and so in cases of gastrointestinal dysfunction, the peptide carriers are acting. And so this will lead to absorption of these peptides, and this will increase the integrity and blood flow to the intestinal vessels, to the intestinal wall, beside its action as absorption of amino acid used for growth. So balanced peptide profile will support the gut integrity. Maintaining gut integrity is very important because it will lead to normal nutrient absorption, and the barrier function will limit the passage of pathogens like bacteria and viruses and antigen. So balanced peptide profile will support the gut integrity more than amino acid hydrolyzed formula. And this study was done on animals and found that the balanced peptide profile formula enhanced gut structure and function, enhanced nutrient transport, enhanced structural integrity more than amino acid based formula. Also, the peptide-based formula will help anabolism. Why? Because whey predominant protein is of high quality, containing high biological value, and will lead to high net protein utilization and high protein efficiency ratio. At the same time, it contains high content of branched chain amino acid, which will stimulate protein synthesis and will reduce the protein catabolism, will stimulate skeletal muscle growth, and branched chain amino acids are precursors of glutamine synthesis, which is essential for energy source for epithelial cells and muscles. Also, peptide-based formula has a role in protection because, as we know, glutathione is one of the most important antioxidants, and the rate-limiting amino acid for production of glutathione is the cysteine. And as we can see in this cartoon, whey contains 7 times more whey predominant protein produce cysteine 7 times more than casein predominant formula, and so it will lead to more production of glutathione combined with vitamin A, vitamin C, vitamin E, selenium, and zinc. They have antioxidant effect, will help to protect cell membranes against damage and will protect against lipid peroxidation. Finally, peptide-based formulas, like in our market, Peptamen Junior, are indicated in cases of maldigestion and malabsorption, whatever the cause, cystic fibrosis, and we'll hear about it, intractable diarrhea, cancer, enteritis, ulcerative colitis, short bowel syndrome, Crohn's disease, ulcerative colitis. In cases of delayed gastric emptying and gastroesophageal reflux and difficult swallowing problems like in cerebral palsy, food intolerance, severe growth failure, some critical illnesses which are admitted to the PICU like trauma, burns, sepsis, and during transition minute total parenteral to the enteral nutrition. My take-home message: if the gut works, use it whenever possible and as much as possible. Make the appropriate choice of nutrition for your patient. You can use complete polymeric diet for healthy gastrointestinal tract function. If you need more calorie, more protein, use polymeric diet for healthy gastrointestinal tract, patient with healthy functioning gastrointestinal tract. Peptide-based formula used for patients with compromised gastrointestinal tract will lead to increased caloric needs, will lead to increase the caloric needs, will help in maldigestion and malabsorption, and will optimize gastrointestinal tolerance in these patients and give them anabolic and protective effects. In summary, the presence of whey will lead to, will give high quality protein, will improve protein synthesis, will lead to rapid gastric emptying, boost immune function, and it is rich in branched chain amino acids, which will help in anabolic effect. Presence of peptides, tri and dipeptides, will lead to balanced profile that facilitate absorption and help gut to support gut integrity. Presence of medium chain triglyceride will lead to a better gastric emptying, will optimize fat absorption, and have protein sparing effect. Finally, the peptide-based formulas like Peptamen Junior can be used for both tube and oral feeding, and better to be, it is lactose-free, gluten-free with low residue to help in tolerance of gastrointestinal tract. Before I leave, I should mention that usually prevention is better than cure. Prevention of malnutrition is better than treatment of malnutrition. And good nutrition will build our future, will build our economics, and will help in sustainability. Nutrition is very important. Nutrition is the master of everything. Thank you.
شكرا دكتور إيهاب. Thank you, dear professor, for giving us such a background on the use of peptide-based formula. والحقيقة دكتور إيهاب هو أهم decision في أي patient هو أنا لو البيشنت هياخد oral nutrition supplement إمتى أستخدم هذا ال oral nutrition supplement، سواء هو polymeric في ال majority of cases، سواء هو peptide-based في ال indications اللي احنا بندسكس النهارده. ويشرفني دلوقتي ان احنا معانا دكتوره الاستاذه الدكتوره حنان ابراهيم، Professor of Pediatric Intensive ICU, Professor of Pediatrics and Pediatric Intensive ICU, Head of PICU Unit.
شكرا استاذه الدكتوره ياسمين. انا يشرفني وجودي النهارده مع الاليجنت جروب الحقيقه، واشكر نسلة هيلث ساينس for the arrangement of such a wonderful meeting اللي بيتاتش الحقيقه very important subject و very essential. I will start the share screen. واضحه كده يا دكتوره ياسمين؟
ايوه يا فندم. نحب نفكر الناس دكتوره حنان ان هم they can send their questions في ال Q&A علشان بعد every specialty will be discussed. It will be open for questions and discussions for 10 minutes.
Okay. Actually, I will talk about nutritional therapy and peptide-based formula in pediatric intensive care unit. I would like to name it as nutritional therapy. It is not a nutritional support. Because in medical care, the paradigm of therapeutic nutrition is now replacing the traditional supportive nutrition. So the nutrition is some sort of a therapy. It is not just a supportive care. We all know that critically ill patient is at nutritional risk actually because of the hypercatabolic state or hypermetabolism, the feeding intolerance, which is very common among such cases, and because of the GIT malfunction. Sepsis, trauma, systemic inflammatory response, and the common miss nowadays. احنا في إيرة الكورونا وبنشوف حالات multi organ systemic inflammatory response كتير. In all these indications or diseases, we meet the hypermetabolism or the hypercatabolic state with increased nutrient requirements together with losses. عيان ال ICU, he can lose a lot of biologic fluid with poor oral intake. Usually they have macro and micronutrient deficiencies. This will lead to malnutrition among them. Malnutrition in ICU is a very bad الحقيقة because this leads to delayed weaning from mechanical ventilation, prolonged ICU stay, and secondary sepsis. Intolerance of feeding in ICU is very common in up to 60% of cases. It carries many names الحقيقة. احنا ممكن نشوف عيان عنده paralytic ileus, just abdominal distension, vomiting, GIT bleeding. It's a gut malfunction. It's a gut malfunction which is manifested in the form of feeding intolerance and even severe malabsorption. Why? ليه عيان ال PICU أو Pediatric Intensive Care Unit has some sort of intestinal gut failure. Those are the components that forms the gut wall. First, there is the microbiologic barrier, which we call the microbiota, then the chemical barrier, then the physical barrier, which is the epithelium, then the immunologic barrier, which is the gut and multi-associated lymphatic tissue, and finally the muscle layer. I can tell that each single layer during critical illness is affected during critical situation. عندنا microbiome alteration due to the suction, the trauma, the use of antibiotics, loss of mucin integrity, destroyed تماما the tight junction between the cells with accelerated cell apoptosis. At the same time, there is atrophy of the gut due to malnutrition or delay of enteral nutrition, and we have the common dysmotility of the gut. All this lead to gut malfunction in critically ill patients. Dysmotility is very common among a critically ill patient, either due to the original pathology like hypoxia, post-arrest, sepsis, or trauma, or due to medication that we can give to the patient, sedation, muscle relaxant. So the stomach, there is reduced enteral contraction, abnormal fundus motor activity, gastric dilatation. Small intestine, we have abnormal duodenal contractility, which impairs the food tolerance, food clearance from the proximal duodenum. الكولون كمان بيبقى فيه reduced colonic motor function. This is what we call the lazy gut. الgut of the patient بتكون كسلانة جدا نتيجة decrease electric activity. We can see here this is the normal volunteer gut electric activity, and this is the critically ill patient. We can see it's nearly flat because of what I already mentioned. Gut dysmotility is multifactorial due to decrease in the gut hormone, increases in cytokine release, many medications that we give to the patient. This will lead to what we call the lazy gut. ICU patient, if this ICU patient has poor nutritional status, which is a common experience in ICU, this will lead to loss of lean body mass, muscle weakness with many drawbacks. Actually, you cannot wean the patient from mechanical ventilation because of muscle weakness. In about 60% of cases, we have negative micronutrient balance, we have immune dysfunction, we have delayed wound healing, and prolonged ICU stay, as I mentioned before. Of course, as mentioned by Professor Ihab, enteral-parenteral is much better than parenteral nutrition, because enteral nutrition prevents villus atrophy, maintain gut-associated lymphatic tissue, as the lymphatic tissue feeds directly from the lumen. It doesn't feed from the blood supply, and of course less bacterial translocation and proper glycemic control with enteral nutrition better than parenteral nutrition. Okay, how to choose enteral formula in critical patient? Therapeutic enteral formula not only have to meet the basic needs. I'm not just, I have to fulfill the calories, the protein, the carbohydrate, the fat, all this is okay, but I have to give a specific pharmaconutrient that may attenuate the hyperinflammatory response, enhance the immune response to the infection, improve gastrointestinal intolerance, and help for better absorption. If I found such a formula, it would be very nice. Actually, this is why we usually in ICU we use peptide-based formula when it is feasible. ليه peptide-based formula؟ مش عايزة أعيد اللي وقرأ الأستاذ دكتور إيهاب خيري قاله، but I have to mention إن peptide-based formula المين protein is the whey protein, which is high quality protein, improve protein synthesis, rapid gastric emptying, which is very important such situation, improve immunity, important source of antioxidant. واحنا عارفين إن عيانين ICU عندهم very high oxidant stress. كمان it is peptide based. طبعا this facilitates absorption, balanced profile, and support gut integrity. Again, the medium chain fatty acids optimize fat absorption. It can spare the protein. It has a protein sparing effect. This is why we choose to use peptide-based formula in such a critical patient. Okay, so the key functional pharmaconutrient, anti-inflammatory nutrient, immune modulating nutrient, and again tolerance promoting formula. This is very important. Nestle Health Science asked me to talk about one case presentation that we use the peptide-based formula in ICU with a good prognosis or a good response. Actually, we have a full study. This is our study, which is on the PubMed, peptide-based formula versus standard-based polymeric formula for critical ill children. Is it superior for patients' tolerance? This study was done by my dear Professor Mirvat Mansour, Professor Yasmin Gamal, and myself, and it is published in 2017. We did this study over 1 year for all patients who were hemodynamically stable without dysfunctional gastrointestinal tract that can prevent enteral nutrition, and it included 180 patients. We classified them into two groups, half of them, and we take it sequentially. One patient received the peptide formula, and the next patient received the regular polymeric formula. We did nutritional assessment for the whole group: weight for age, body mass index, skin fold thickness, mid-arm circumference, at admission and on discharge, this scoring, and we applied the WHO gross charts. Nutritional assessment and feeding assessment during pediatric intensive care unit included the intake, the requirement, and resting energy expenditure, days of nothing orally taken, days to reach full intake, which was very important, signs of feeding tolerance like bleeding, ileus, reflux, and abdominal distension. We also calculated the frequency, the duration, the causes of feeding interruption during enteral nutrition were all observed, and the time needed to reintroduce the feeding again was reported also in all the 180 patients. We assessed the outcome like the fate of the patient, died or survived, days of mechanical ventilation, length of ICU stay, sepsis days, and use of vasopressor agent if needed in any patient. This table shows the demographic and the clinical characteristics of the study population and the different diagnoses like epileptic patient, bronchopneumonia, encephalitis, septic shock, even 3 surgical patients with colon bypass, polytrauma, heart failure, and bronchial asthma. This is an important table. This is the nutritional follow-up for both groups. We can see here certain important results. This is the frequency of feeding interruption. We can see here 4.2 in standard formula, and it is 1.7 in peptide-based formula, and there was a significant difference between them. Again, the duration of feeding interruption was much more longer than that of the peptide-based formula. The increased gastric residual volume here was 60, here only 12, with significant difference between them. Abdominal distension, 60%, here only 3%, and so on. So we concluded that peptide-based formula feeding showed better tolerance than the standard polymeric formula in critical ill children, minimal feeding interruption with better feeding tolerance, faster and full caloric intake, and improved weight gain. I have to tell that there was no significant difference as regards the mortality between the two groups, but the hospital stay was significantly different between the two groups, and the discharge from the ICU was actually faster among patients who received the peptide-based formula. My take-home message is that feeding an ICU patient now extends beyond choosing the right feeding route, rate, intake. It's a therapeutic nutrition that offers fresh hope to improve the outcome of ICU patients, and I can tell that peptide-based formulas have better tolerability and higher benefits among the critical patients. This is my BQ team. I am very proud of all of them, and thank you.
Thank you, Professor Hanan. Thank you, Professor Hanan. Thank you, the Pediatric Intensive Care Unit of Ain Shams University. الحقيقة they are really behind the nutrition support of their patient علشان the best outcome. بروفيسور حنان من الناس اللي يعني الشغل مع الكلينيكال نيوتريشن تيم والكلينيكال نيوتريشن سبورت تيم في الهوسبيتال طبعا with بروفيسور دكتور ايهاب وبروفيسور دكتور مي مع دكتوره حنان للسبورت of our patient. We tried the peptide-based formula. الحقيقه هي it was published 2017 but we tried the formula 2015 with a better tolerance. We will take a few questions لدكتوره حنان و discussion of the use of the peptide-based formula في ال critical care. دكتور حنان حضرتك معانا؟
معاكي يا دكتور ياسمين.
Okay. We have a question from an anonymous attendee. Difference between lazy gut and paralytic ileus. This is a very valid question دكتور حنان لأن احنا بنقول lazy gut و lazy gut is an indication of the use of peptide-based formula. يعرفوها ازاي؟ And how to manage.
Paralytic ileus is the extreme of lazy gut. It is the severest form of the lazy gut. وهنا it's honestly to say there is gut failure score. والسكور ده بياخد درجات وبنحكم على العيان بديفرنت جريدز. في العيان اللي بياخد بنوصل لجريد 3 or 4 we do not try enteral nutrition. We have to improve the risk factors. يعني لو عنده هايبوكاليميا بنحسنها، هايبوتنشن بنحسنه، سيفير سيبسس بنشتغل عليه لغايه ما نلاقي ان العيان الابدومينال ديستنشن عنده قل، الريزيدوال ايفن بعد اورال ميديكيشن قل. we can try small boluses enteral feeding. لو العيان استجاب we can continue. احيانا الجري زون ده ما بيبقاش واضح، بس اذا كان العيان على جريد 3 او 4 we do not try until we improve the etiology of the condition.
طيب would you advise a patient if he is MPO for a period that is more than 48 to 72 hours ان احنا الستارت فورمولا تبقى peptide based ولا polymeric formula دكتور حنان؟
according ليه احنا حصل delay للانترال nutrition. If the delay in enteral nutrition due to severe critical situation or due to gut manipulation like surgical cases, of course I have to try first the peptide based formula. لكن لو العيان عنده healthy gut او انا I can suggest ان العيان ده I can predict ان العيان ده عنده healthy gut, I can start with polymeric formula عادي.
polymeric formula what you mean is high calorie formula اللي هو 1 كيلو كالوري في ال 1 مللي زي مثلا ريسورس.
No, I know I mean standard formula.
Okay, standard polymeric formula. طيب, we have some questions from pediatricians from India, I believe. Dr. Kalpana Shetari. What's your advice for feeding patients who are on a ventilator or a CPAP?
We have to feed all patients on a ventilator or CPAP.
Yes.
All the concepts.
As soon as possible. As soon as possible.
And follow the bundle, the VAP bundle, to not to cause ventilator-associated pneumonia like semi-sitting position, use the proton pump inhibitor, follow the gastric residual volume. Sometimes you can use infusion instead of high boluses, whatever you can do, but please don't stop enteral nutrition.
Some of Indian pediatricians also are asking about the use of F100 and F75 for PQ-sick patients.
Okay, this is for you, Dr. Yasmin.
If I can answer this, we don't have in Egypt the F75, and the F75 is indicated for severe acute malnutrition. And the F100 is for the follow-up of the patient for catch-up formula. Luckily, unfortunately, in Egypt, we do have different formulas that can cover our patients if they have acute severe malnutrition, or if they need the catch-up, we have the high-calorie formula for their catch-up. So we don't choose this, and it's indicated, I believe it is used in a lot of countries, India included, for the management of severe acute energy malnutrition. But we do modulate. Nutrition is personalized, and we calculate for each patient the needs. The severe acute malnutrition, we need adequate protein, 0.9 to 1 gram protein, and we don't need the high calories. Once the patient is recovering and bypassed the catabolic stage, we can shift to the high calorie formula or the oral nutrition supplement. So Dr. Hanan, there's a lot of comments about, and thanking you about this wonderful presentation. and they are asking about different uses. Is it used in cystic fibrosis? Is it used in Crohn's disease? Is it used? So keep with us. We will answer all these questions. All the professors will answer the question about the use in different specialties. Thank you, Professor Hanan. So I have the honor to introduce Professor Iman Fouda, Head of Pulmonology Unit, my dear professor, and she will discuss with us the experience of the Pulmonology Unit in using peptide-based formula, I believe in cystic fibrosis, because this was a recurring question. Professor Iman.
Thank you, Professor Yasmin. Good evening, everyone. I would like at first to thank Nestle Health Science for giving me this chance to share our experience in Pulmonology Unit, Pediatric Hospital and Shams University with all my colleagues in Egypt, in Africa, and in Middle East. Actually, this is very good choice to talk about optimizing nutrition with different pulmonary disease, and of course, our patient today with the patient with cystic fibrosis. Okay, let me start by telling you the story of one of my patients. She is Mona. She is 5 years old, presented with history of frequent hospitalization dated since the first days of her life with pulmonary infections, and at least this happened once every 2 months. She has a history of PICU admission twice, frequent courses of IV and oral antibiotics. She has also chronic diarrhea with steatorrhea, failure to thrive, poor weight gain with stunted growth, and of course, she's not able to share in any activity or going to any school. This is the growth chart of my patient, Mona. Her weight is 12.5. I'm reminding you, she's 5 years old. Height is 95 centimeters, and the patient is underweight and height and below the 5th percentile, as you can see in her growth chart. This is a CT scan of the patient, and as you can see, she has advanced bronchiectasis involving all lobes of the lung bilaterally. Of course, due to the presence of respiratory manifestations and GIT problems in the form of steatorrhea, we suspect cystic fibrosis. So sweat chloride test was done, and the result was 141, and the positive cases, as you all know, if it is above 60. And gene study had been done for the patient, and it revealed that the patient have the worst type of gene mutation of cystic fibrosis, which is delta F508. As a part of our routine work in any case of cystic fibrosis in our pulmonology unit, we have done bronchoscopy of the patient, and bronchoalveolar lavage had been taken, and the culture and sensitivity unfortunately revealed the presence of the characteristic organism, which is Pseudomonas aeruginosa, which is actually one of the common organisms in those patients, and it leads to rapid destruction of their alveoli and terminal bronchioles. So what we have now is a case of cystic fibrosis with poorly controlled respiratory condition, and she is malnourished and stunted growth. Back to our original disease, which is the cystic fibrosis, actually, which is the most common life-threatening autosomal recessive disease. Every system in the body had been affected by this disease, but on top of which is the respiratory disease due to advanced bronchiectasis, and the GIT due to exocrine pancreatic insufficiency, which affecting the fat absorption, affecting the absorption also of fat soluble vitamins. Actually, due to the advance in the treatment of cystic fibrosis cases, the survival of the patient increased among the last 4 decades, thanks to many lines of treatment consisting of antibiotics, airway clearance, physical therapy, and so on. But on the top of which, don't forget nutritional support. Sometimes when we are dealing with cystic fibrosis patient, we are concentrating on the respiratory manifestations only. But please take care, nutritional improvement is the keystone of the current global effective treatment to reduce the burden of mortality and morbidity resulting from the cystic fibrosis. Children with cystic fibrosis, as you all know, often experience stunted growth and failure to thrive. nutritional status play a huge role in those children well-being. And there is a great link between the pulmonary manifestation and involvement with the nutritional status. Both are closely related. The chronic malnutrition in CF is the independent factor which affecting their survival. It is one of the causes to lose their pulmonary function. And it is one of the missed causes of the recurrent respiratory exacerbation. So when you are dealing with case of cystic fibrosis, please, you are concentrating on managing the respiratory problem. Please don't forget, is one of the causes of recurrent respiratory exacerbation is the presence of the malnutrition. And we have an alarm here. We should all know that the parameters of growth, including the weight and the height of cystic fibrosis patient at 3 years, associated with lower pulmonary function test and more deterioration of pulmonary function at the age of 6 years. This is the anthropometry of our CF patient in pediatric hospital in Shams University. 82% their weight is below 5th percentile. The height, 85% of them below the 5th percentile. 70% of them have body mass index below 5th percentile. And to this finding, due to the Mona case and the other cases, we start again a research about the nutritional assessment and rehabilitation in children with CF and other causes of bronchiectasis, their effect on pulmonary function and the clinical severity. This research had been under the supervision of my dear colleague, Professor Yasmin, and also Professor Asma El-Husseini and myself. The aim of this work was to assess the nutritional status of our children with CF among the patients attending our hospital, and to study the effect of short course of nutritional intervention program and the effect on their growth, pulmonary function, frequency of acute exacerbation, and rate of hospitalization. When we started this research, we put some upon our mind. What are the nutritional challenges we are dealing with cystic fibrosis patient? Number one, we have feeding intolerance. So I should choose a diet, a formula which is well balanced, at good tolerance. This is very important because most of our patients have delayed gastric emptying, should have better absorption by giving the middle chain triglycerides, and this formula should be palatable. We have also malabsorption and impaired GIT function. So I should give pancreatic enzyme replacement, and I should again choose very efficient formula with better absorption. I have a problem of hypermetabolism due to the recurrent respiratory tract infection. So I should control the pulmonary infection, and I should give high calorie containing diet. I also have high nutritional need in those patients, in addition to micronutrient and macronutrient deficiency. So I should use a formula which is nutritionally complete, containing the recommended daily allowance of all nutrients. And I shouldn't also forget that I should protect the GIT. The GIT in those patients actually is exposed to many harm. So I should choose a diet with enhanced antioxidant activity. So all these are challenges I am meeting with the CF patient, and these are the criteria I should concentrate on choosing my formula in managing on those patients. We choose in the beginning 40 patients, their age between 2 and 16 years, and compared them with 40 healthy children. Subjective global nutritional assessment was done, and also 24-hour dietary records of all the feeding of the patient. We have done anthropometric measurement, height, weight, skin fold thickness, mid-arm circumference, body mass index, and also body composition, body fat, fat-free mass, muscle mass. All are these criteria to indicate what is the body composition of those patients. Then we started our nutritional intervention program, which actually the duration was 9 months to start with. Each patient was given an individualized plan. We give the energy requirement for this patient between 150 to 200% for the same age of healthy children and the adolescents according to the schedule. And we are concentrating that 50% of the energy requirement coming from the carbohydrates, 20% from protein, and 30% from fat. 50% of the energy requirement were given through high calorie supplement, 1.5 kilocalorie per milli. And due to all these reasons and due to importance of choosing actually the formula very accurately, we put our patient on peptide-based formula. Actually, we used the Peptide-Based for better tolerance, better absorption with component which enhance the gut antioxidant profile. This is the requirements of calories in a normal patient compared with CF patient. As you can find, it's 200% over. It means double the requirement of normal children. And our aim is different according to the age. We want to reach the normal weight and length for age if the child below 2 years. Body mass index with a difference 1 year beyond the chronological age of the patient if he is between 2 and 12 years, and exactly to target the needed body mass index if the patient above 12 years. And these are the recommended daily dose of the micronutrient and the micronutrient for patients with cystic fibrosis and pancreatic insufficiency, including the fat-soluble vitamins. During the nutritional interventions, we took care of keeping the body composition of the patient. As you can see, this is the curve. This is our baseline, and starting to increase with starting the peptide-based formula. And what is also what happened as regarding the recommended daily allowance of the calories. All regimen of CF, including antibiotics and airway clearance, were given as usual. Nutritional supplementation was very strict, in addition to pancreatic enzyme replacement, vitamins, and minerals. And we followed the patient through telephone calls, short messages. And at the end of the study, this patient assessed again clinically pulmonary function and frequency of hospitalization and the use of antibiotics. What about our results? Our results showed that almost 57% of studied patients were moderately malnourished, 23% severely malnourished, 66% were underweight, and 50% with stunted growth. This is the before starting our nutritional course. Then this is the anthropometric measure of our patient compared to the control. As you can see, significant difference between patient control as regard weight, height, triceps skin fold thickness, body mass index, and mid-arm circumference. This is comparing our patient with the control. So anthropometric measures was markedly decreased compared to control. Then starting our nutritional rehabilitation actually with peptide-based formula with the Peptide Junior. And this is the comparison between pre and post. Market improvement in the weight centile Z score, height, mid-arm circumference, triceps fold thickness, and body mass index. This is after 9 months of treatment. Then we are clinicians, so we compared the patient pre and post as regard recurrent attacks of fever, production of yellowish sputum, degree of dyspnea, occurrence of wheezes, and hospitalization. And again, after this nutritional intervention, marked improvement had happened in all the clinical score. Even the days of absence of school, the use of bronchodilator in the form of short-acting beta-2 agonist improved a lot after we start this intake with the peptide-based formula. Pulmonary function, we found the positive correlation between the one of the parameter of pulmonary function and the body mass index. The higher the body mass index with good nutrition, the more improvement in the forced vital capacity. Conclusion from this study that the children with CF are significantly malnourished compared to their healthy peers. Nutritional rehabilitation has a great impact on their respiratory symptoms and anthropometry, body composition, and pulmonary functions. Actually, the nutritional rehabilitation decreased the acute exacerbation frequency and number of hospital admissions. So treatment of CF should address the energy and protein deficit, the better tolerability and absorption of those patients, and of course, including long-term monitoring of weight and growth. This is back to our patient Mona. This is what happened, her body composition pre and post. Improvement in her body fat, in fat-free mass, in muscle mass, and most important also, number of hospitalization among the 9 months. Once only she had been admitted compared to before 4 times. And in addition to the respiratory care which had given to the patient, we can get rid of her Pseudomonas aeruginosa in her bronchoalveolar lavage. This is, of course, the goal of the respiratory physician plus the nutrition group. Don't forget, please, that optimum nutrition care is important in management of cystic fibrosis as an essential part in multidisciplinary team. So cystic fibrosis is not only respiratory. We should care about the nutrition also. The good choosing formula for those patients should stress on the presence of component with better tolerability and absorption and high GIT protection power like the peptide-based formula as Peptide Junior. And thank you.
Thank you, Professor Iman. Now, Dr. Ahmed Saleh, Director of Nutrition and Pharmaconutrients, will present the results of the study. Thank you.
Thank you.
Thank you.
Thank you, Professor Iman, for a lovely lecture and lovely support for cystic fibrosis patient. The first question that we have, do we plot cystic fibrosis patient on normal growth charts or they have special growth charts?
No, they have a special growth chart. Actually, the Cystic Fibrosis Foundation recently have done a special growth chart for those patients. So if any of my colleagues need this chart, I can send it to them through their emails so as they can follow their patient on these special charts.
We have also another question. What is the role of vitamin D in respiratory disorders? I believe this is another lecture.
Yes, my vitamin D now is involved in everything. Everything in our life, vitamin D play a role in it. Vitamin D actually is working as immune modulator. So it helps in minimizing the number of respiratory tract infection in children. And this study has been done in our hospital, also comparing the patient with recurrent respiratory tract infection when we put them on the vitamin D supplementation after assessing their basal vitamin D. In our patient cystic fibrosis, as you all know, vitamin D is a fat-soluble vitamin and it's very important for those patients, and they are going to take this vitamin for life.
Thank you, Dr. Iman. We have a lot of thank yous and a lot of questions. We have also questions to Nestle Health if there is Peptamen in India. I believe the Nestle Health team can answer this after the webinar and tell us the availability of the product. And we have also a question about the use of Peptamen less than 1 year. Did you use it, Professor Iman?
No, actually, I didn't use it before 1 year. Sometimes you use it at the age of 11 months. This is the minimal age I had used Peptamen in. But I didn't use it.
Let us stick to the shelf, yes. Peptamen is used above 1 year. So thank you, Professor Iman, and I have the pleasure to present my dear professor, Professor Dr. Omnia Rashidi, Professor of Pediatrics and Pediatric Neurology. Dr. Omnia, are you with us?
Yes, Yasmin, hello. Assalamu alaikum.
Welcome, dear professor. تفضلي حضرتك.
Bismillah ar-Rahman ar-Rahim. I want at first to thank Professor Dr. Mustafa Al-Hodhod and all my colleagues sharing in this scientific event, Professor Dr. Ihab, Dr. Hanan, Dr. Iman, Dr. Ahmad Hamdi, Dr. Muhammad Hisham, Dr. Yasmin Gamal. It's really a very nice team to share with this scientific event. Also, I want to thank Nestle Health and company and CCG for organizing such a scientific with all event with all these stars. I shall start today. I shall start sharing my screen. Can you hear me?
Yes, Dr. Omnia, we are hearing you.
Okay, I shall start. Okay, that's okay, Dr. Ihab?
Yes, okay, Dr. Omnia.
Okay.
Can continue.
Today, I will share with you a certain experience, one experience about our concerns as neurologists about nutrition in neurodisabled patients, especially cerebral palsy. I will start with Kevin. Kevin was a case we shared together, me and Dr. Iman Fouda and Dr. Muhammad Hisham, this case, and I think they will remember the case when the video starts. Kevin is an 8-year-old male patient. He's already diagnosed as post-anoxic dyskinetic quadriplegic cerebral palsy associated with epilepsy, mental and linguistic delay. Really, Kevin presented to me at the age of 2 years. I'm following him up to 6 years up till now. He was stable on his anti-epileptic drugs, which was valproate, anticholinergic drug for his dystonia. It was trihexafendyl or Artan. muscle relaxant, which was baclofen, and clonazepam or Rivotril, as known to all, for his dystonia and an abnormal movement, and as a muscle relaxant, as an anti-epileptic, and he was on physiotherapy session. At that time, he received all his food intake orally in the form of semi-solid food. The child weight was on the 30th centile for his age, and this is accepted for us in all developed countries for patients with CP. 2 years ago, the mother complained of difficulty of feeding her child. And I think difficulty of feeding her child, as nutritionists always advise up, in the form of prolongation of the time of feeds. Her feed was about 3 hours, and the child was crying and increased abnormal movement, irritable, and very nervous. Okay, this is not going good. So we advise her, we go to a pediatric nutrition in our pediatric nutrition clinic headed by Dr. Ihab, and the staff there advise for oromotor rehabilitation sessions and to make feeds much smaller and frequent diet. Oromotor sessions. Oromotor sessions in developing countries is very, very restricted. A small number of people who knows about oromotor rehab and the importance of oromotor rehab. So I would like to spotlight on this area. Yet, Kevin suffered more and more from his feed, but the things that happened that turned our attention was the recurrent chest troubles and hospital admission and seek medical advice of Professor Dr. Iman Fouta. Recurrent chest troubles along the past 1 year and hospital admission with aspiration pneumonia. Why CP patients are prone to respiratory troubles? This article published in Frontier Pediatric, 24th of June, 2020, about the evaluation and management of respiratory illness in children with CP. They said that the main cause of respiratory illness in these children is oropharyngeal dysphagia. Oropharyngeal dysphagia, causing pulmonary aspiration of food, drink, and even their own saliva. This is the main issue in our CP patient. Please remember that. So I look about the respiratory illness in cerebral palsy. What are the causes? As we said, dysphagia, and especially oromotor dysphagia, oromotor dysfunction of these muscles. This may be related to the poor head support, scoliosis, unstable pelvis, his weakness, his abnormal tone, his poor coordination, leading to this motor disorder. Another issue is the GI dysfunction. Again, the GI dysfunction, including drooling and oromotor dysphagia again and again, gastroesophageal reflux, their delayed gastric emptying, and constipation. To be noted, these GI symptoms increase more and more with malnutrition. So we have a vicious cycle here. Another one is malnutrition per se can lead to respiratory illness in CP. From the constipation, chronic carriage of pathological bacteria, and the weakness of mass of muscles, as Dr. Ihab said. To us, again, there is a chronic airway carriage of bacteria. There's recurrent seizures with recurrent aspiration, increased saliva, increased gastroesophageal reflux, sedation, drugs we are using for anti-epilepsy, especially benzodiazepines, which cause respiratory center depression and increased salivation with increased aspiration. Some of those are asthmatic. All this lead to respiratory illness in CP. We were not alert with our patient. We are supporting him just for his feeds, but not concentrating except when the respiratory illness started and increased with recurrent hospitalization. I think we must be more alert with CP patients about their feeding difficulties from the start, so not to go to this critical point. I asked Professor Iman, and she told me, improve the oropharyngeal function, stop drugs that affects respiratory function as benzodiazepines, and improve his malnutrition. How to do that? How to improve oropharyngeal function? We do our best. We increase oropharyngeal and muscular rehab. We stop benzodiazepine in the form of clonazepam or rivotril. But again, we didn't reach improving nutrition. Why? The patient is very irritable, dystonic, nervous, and we unfortunately can't even go to status dystonicus. What is status dystonica? Dystonia, uninterrupted dystonia. And in a very short time, he lost more than 25% of his weight. He was admitted to our pediatric neurology unit at Shams University Hospital, and we decided to have the multidisciplinary team. From the start, it is written in any book that CP must be managed by multidisciplinary team. Unfortunately, we didn't have the CP clinics as developed countries. We must go through a multidisciplinary team and a special clinic for each diagnosis, especially the diagnoses which are spread in our country as CP. So we have the neurologist, the pulmonologist, the gastroenterologist, and the clinical nutrition all available in our hospital, and we discuss the case. This is the case of Kevin when he entered our unit. Sorry for the miserable video. Severe dystonia, irritability, nervousness. He was about to fall. The mother and father are not sleeping at all. This video in our hospital. Very bad quality of life with very difficult times. No feeds, no sleep. Really, it was so difficult for us as a team to leave the child like that. Not all CP like that, but they may end like that. So, we go to upper endoscopy to see if there is gastroesophageal reflux and barium meal, and there was no gastroesophageal reflux or disease. Kevin stopped all oral feeding, turned to TPN. We treat status dystonicus by benzodiazepines. It is by midazolam or dormicum drip. And after everything is relieved, we tried oral feeding. But patient was so irritable and nervous, and we cannot proceed in oral feeding. So a decision of insertion of gastrostomy tube was taken after pediatric surgeon consultation, Professor Dr. Muhammad Hisham. Tube feeding was encouraged by all the decision maker. The pulmonologist, she wants to decrease the aspiration, decrease the respiratory affection, decrease the saliva. Gastroenterologist, to improve the gastric emptying of this child, to improve the gut integrity, improve his tolerance. To me, to decrease involuntary movement, nervousness, the clinical nutrition, to improve the caloric intake, and the pediatric surgeon, of course, advised by PEG or percutaneous endoscopic gastrostomy, which really something very nice that happened in our country. That's an easy technique by endoscopy. He can insert an endoscopy tube. From the same paper, 2020, written, correcting malnutrition, usually by increased calorie or feeding tubes, improve constipation, GERD, and overall participation. We know that. But again, in this paper, they raise up the issue. Of note, Families sometimes feel their children are less healthy with a feeding tube, even where they are nutritionally more healthy. That's mean we, as a culture and developing area, we don't have the idea or thinking about tube feeding by tracheostomy tubes. The child look unhealthy to us. It's just a myth. So we must change our idea, even as a doctors. Sometimes doctors say this is an invasive technique to do something like that. No, it is not an invasive. It is very important to do it at a certain time. So we must raise the issue about feeding and importance of feeding of cerebral palsy patients and when to use tube feeding. According to our protocol, we started with, after insertion of the tube by Professor Dr. Muhammad Hisham, we started hydrolyzed peptide-based formula to improve tolerance with good gastric emptying. And there is a big research with Professor Dr. Yasmin and Professor Dr. Hisham about tube feeding and using this peptide-based formula as said by Professor Dr. Ihab for its tolerance, protection, gut integrity, and anabolism. And we start Peptamen Junior for 3 days. Then we turn to soften food as gradual advised by our nutrition team. I was so happy. His chest was clear. I can use benzodiazepines again. So I returned to my Rivotril and the patient can be again much calm and improving. How is Kevin doing now? He's gaining his weight steadily. There is no respiratory troubles. His motor and cognitive function are improving. The quality of life of the boy and the sleep pattern and his family was much better. His oral motor function even improved, and the mother started to tell me that she's beginning again to reinitiate oral feeding by mouth, and he's getting his money, and now he has a mixed type of feeding, oral and via the tube. So, poor growth and malnutrition is an important secondary health condition that impacts the global health and well-being of children with CP and their family. My message from this case was every patient you see with CP, whether you are a pediatrician or a neurologist or whatever, you must look on his feeding, on his weight. It's not our job to do it. Please ask for our clinical nutrition consultation to start as early as possible, so not to go to a vicious circle. Because malnutrition will lead to decreased muscle strength, impairment of motor function, respiratory musculature weakness, with impaired cough and resulting pneumonia, affection of the heart by diminished cardiac work, increased circulation, predisposed to congestive heart failure. Again, you will affect your job in motor acquisition, in cognitive development, in behavior, in social interaction. It will affect the whole life of the child. Affects the immune response with the increased infection. It increased gastroesophageal reflux, and gastroesophageal reflux lead to dystonia. Usually, Sandifer syndrome. Said in this disease, there is reflux with dystonic neck. And again, the dystonic neck make reflux, so it is vice versa. So lessen the symptom associated with gastroesophageal reflux, improve nutrition, you will improve both and you do not enter to this vicious cycle. Again, malnutrition, wound healing, affection. If you want to do fundoplication, the healing will be very bad. So malnutrition affects the whole systems of the body. Don't reach to malnutrition, as said by Professor Dr. Ihab, prevention. Prevent it from early. Keep your eye on feeding of this child. I know in the past we don't have oromotor sessions in Egypt, we don't have specialists in nutrition, but now there is specialists everywhere. Again, if you have a respiratory complication in patient with CP, please go to the specialist, the pulmonologist. So he is highly specialized in this issue. So you need a multidisciplinary team, a physiotherapist, oromotor, OT, nutrition, pulmonologist, GI, and we work together in a team. So my home message is that nutrition has a magical role in the management of CP. We must start now all to start the multidisciplinary plans to be tailored for each of our patient of CP patient. Thank you so much.
Thank you, Professor Omnia, for this perfect presentation and this case. Actually, there are a lot of messages to thank you for this meticulous, elegant, perfect presentation. And there are some questions to you, Professor Omnia. Are you ready?
Yes.
Okay. They ask about, do you think that malnutrition was the main cause of reflux and the main cause of dystonia in this patient?
We think
just predisposed to this dystonia.
Yes. You see, we know reflux can cause dystonia, and dystonia can cause reflux. Both are vicious together. But in this patient per se, before introduction of the tube, we do endoscopy for him, and barium meal before the introduction of the tube. Because if he had GERD, we have to do fundoplication. But I think this was a functional lesion and not organic. It is a functional oropharyngeal dysfunction rather than gastroesophageal reflux. In spite of the fact this patient was given proton pump also.
Okay, so do you prefer the gastrostomy or jejunostomy tube for this patient? Which is much better in cases of reflux and dystonia?
They prefer jejunostomy in this case, yes. And Dr. Muhammad Hisham, he told me that he will try to put the tube as he can. And fortunately enough, it was jejunostomy and not gastrostomy.
Okay. Yeah, and in this case, when we use jejunostomy, not gastrostomy, so we should use peptide-based formula like Peptamen, not the polymeric formula, because polymeric formula should be put into the stomach. Okay, do you think that the improvement of nutritional state is just an helpful, or it is a cause for correction of the these dystonic movements?
I think if this patient was fed accurately and picked from the early development of this child, maybe from me 6 years ago, we don't have this science in our country. The nutrition, the feeding of CP, the oromotor functions, how to follow them. I think this type of science is developing more and more in our country. So I think now in small young ones coming to me, I'm trying to put an eye and to consult a nutritionist as soon as possible.
Okay. Some ask for how long this patient will be on the jejunostomy tube.
I think you can stop it. You can close it at some time if you improve the malnutrition and the oral intake is as good as we think on the chart. The mother called me really, and I told her, she's telling me the child is taken by mouth. Shall we go to Dr. Hisham and ask him to close it? No, because he didn't reach the nutrition status that we want. So I told her just complementary feeds will benefit the child. He can take oral and to let as complementary feeds. And again, we have the benefits that if the child got any type of illness, she can turn to the tube feeding and stop the oral, so stop recurrent aspiration and stop more respiratory illness.
Okay. Thank you, Professor Omnia, and thank you for highlighting the importance of clinical nutrition besides the neurologists in the management of cases of cerebral palsy. Okay, thank you, Professor Omnia. And now we will shift to another specialty, and it's my honor to introduce my dear colleague, Professor Dr. Ahmed Hamdi, Professor of Pediatrics and Head of Gastroenterology Unit, Ain Shams University, to present his case and the comments about the case. Welcome, Professor Ahmed.
Welcome, welcome, Professor Ihab.
Okay, you can start now?
Okay. Assalamu alaikum wa rahmatullahi wa barakatuh. Good evening, everybody. Welcome, our guests and audience. It's my pleasure to be with my professors. Thanks to Nestle Nutrition Health for organizing this great event. I will present an interesting case which is commonly seen not only by the specialized gastroenterologists, but it is commonly seen in general pediatrics practice. An 18-month-old boy, fourth order of birth of non-consanguineous parents, who lives in a slum area in Cairo, Manshayat Nasser. The mother is non-educated, of below average socioeconomic standard. He was referred to our unit for upper and lower GI endoscopies because of chronic diarrhea, growth failure, and elevated fecal calprotectin. He was born at full term. The birth weight was 3 kilograms. He was predominantly breastfed for the first 4 months. The mother noticed he has excess regurgitation, but associated with adequate weight gain. At 6 months, his weight was 8 kilograms. At 4 months of age, the mother started to give him solid foods in the form of cereals, yogurt, biscuits, and juice, but no vitamin and mineral supplementations were given. The mother noticed infrequent attacks of loose stools, and the weight gain was very slow. At 12 months, his weight was 8.5 kilograms. Starting from 10 months, the mother noticed he had intermittent attacks of diarrhea. The motions were loose to watery, 3 to 5 motions per day, containing excess mucus, undigested food, but no visible blood. The attacks last for 4 to 5 days, and as claimed by the mother, it responds to the antiseptics, but recur every 3 to 4 weeks. At 10 months, the mother stopped breastfeeding and started to give him diluted fresh animal milk. No persistent vomiting or fever or systemic manifestations. Management before presentation. At the age of 14 months, the mother sought medical advice, and the general pediatrician sought about food allergy and started to advise the mother about elimination of the cow milk proteins, meat, and the soy proteins. And he prescribed amino acid-based formula, which is available now in the Ministry of Health centers. But because of the bad taste of the formula, the child did not accept the prescribed amount. He accepted only about 100 milliliters a day. At the age of 16 months, the weight was still not increasing, the diarrhea is still recurring, and the mother returned to the general pediatricians who thought about multiple food allergy and started to increase the number of eliminated foods, including eggs, wheat, and fish. 2 months later, at the age of 18 months, the weight decreased, and the general pediatrician started to think about inflammatory condition of the gut. And he asked for fecal calprotectin, which was 250 microgram per milligram stool. Actually, this scenario, we see a lot of cases in this scenario, starting eliminating the cow milk proteins, the child is not responding, the diarrhea is not stopping, the weight is not increasing, and the general pediatrician advises the mother to increase the number of eliminated food. The process chart showed decreasing centiles crossing two major centile lines, and now at the age of 18 months at time of presentation, the weight for age Z-score was between -1, -3, moderate underweight. The length was below third centile, and the Z-score of the length for age was -2 to -3, moderate stunting and borderline wasting. On examination, the child is ill-appearing, have moderate pallor, no jaundice, wasted muscles and wrinkled skin, as we see in marasmic cases, moderate abdominal distension, no palpable organomegaly, no evidence of cardiac, renal, neurological, or hepatic disease. Initial labs, stool analysis showed bus cells 10 to 12 per high power field, red blood cells -3 per high power field, undigested food, entamoeba histolytica cyst, fecal calprotectin was 250 microgram per milligram stool. The complete blood count showed moderate anemia, microcytic hypochromic with normal white blood cell and platelet counts. The blood chemistry showed mild elevation of the CRP with mild hypoalbuminemia, normal liver enzymes, normal kidney functions, and severe iron deficiency. So, in a case similar to this, what are the possible causes? Of course, the first differential diagnosis to think about is the primary nutritional disorder due to the bad nutritional history, the early cessation of breastfeeding, the socioeconomic standard, the incorrect weaning practice. And as we know that primary malnutrition leads to gut pathology and immune suppression, leading to recurrent or persistent diarrhea, which increases the malnutrition through the malabsorption, and it leads to a vicious circle. Treating the malnutrition is expected to break the vicious circle and improve the gut pathology and prevent the recurrence of diarrhea. The second possibility is food allergy. Can this presentation be caused by food allergy? Yes. Food allergy, food protein induced enteropathy, FP, presents with failure to thrive, chronic diarrhea associated with mucus, abdominal distension, intermittent vomiting, hypoalbuminemia, and the common food triggers are cow's milk, soya, egg, and wheat. In this scenario, the general pediatrician eliminated all these proteins from the food of the child. But if this case was a case of multiple food allergy, the symptoms should improve within 1 to 3 weeks, and the weight should increase within 1 to 2 months. And to confirm the diagnosis of food allergy, we should have oral food challenge test. And on oral food challenge test in this pathology, vomiting and or diarrhea will appear in 2 to 3 days. The third possibility is celiac disease. Celiac disease is a common cause of malabsorption and growth failure in pediatrics, but the usual age of diagnosis is 3 years and above. Actually, only 7.2% of cases of celiac disease in children were diagnosed before the age of 2 years. And there are reported cases of diagnosed celiac disease before the age of 6 months, but it is very rare. And celiac disease during the first 2 years of life is different from the celiac disease after the age of 2 years, that the anti-tissue transglutaminase, IgA, which is very sensitive for the diagnosis of celiac disease after the age of 2 years is less sensitive before 2 years. And we should use the anti-deamidated gliadin peptides antibodies, IgG or IgA, which are more sensitive but more expensive. Of course, though, there are many other causes of malabsorption and growth failure. We will not discuss in this case. So we decided to reintroduce the eliminated food, each food over a week, and follow up the patient for occurrence of symptoms like vomiting, diarrhea, or skin rash. And actually, all foods eliminated were reintroduced with no reaction to food. This was linked with nutritional advice for the mother and the prescription of a polymeric formula. But unfortunately, after 3 months of nutritional rehabilitation, there is no weight gain. And this situation is not uncommon. It is reported in Pakistan that 65 malnourished infants received 12 weeks of nutritional supplementation with ready-to-use therapeutic formula. 17% of these cases had insufficient response and underwent upper GI endoscopy with duodenal biopsies. So endoscopy can show many pathologies in the upper GI, in the duodenum and jejunum, that may lead to the diagnosis of the cause of chronic diarrhea or intermittent diarrhea and failure to thrive. But first here, we show the normal duodenal mucosa, showing the mucosal folds, the circular folds, and the finger-like projections which represent the villi. And this is the normal appearance of the villi in the duodenum. In cases of malabsorption, we commonly see flat mucosal surface. Notice that is the normal with the velvet appearance of the finger-like projections of the normal villi. Here, the folds are flat. There are no finger-like projections, but this finding is non-specific and can occur in all cases of malabsorption, including PAM. In celiac disease, there are signs, endoscopic signs, which are linked to the diagnosis of celiac disease. These include fissuring, longitudinal fissuring of the circular folds, giving the appearance of the scallop. This is called scalloping of the duodenal mucosa. Here, the circular folds have longitudinal fissures, giving the appearance of the scallop. The duodenal mucosa may show small nodules 2 to 10 millimeters in diameter. It is called lymphoid nodular hyperplasia. It is very apparent here and here. And the most common cause of this pathology is food allergy and eosinophilic gastrointestinal disorders, but it can be seen in celiac disease and H. pylori infection. In fat malabsorption, we commonly see this appearance. The duodenal mucosa is totally covered by a white, creamy, milky-like exudate, which represents the unabsorbed fat, which may form a complete coat of the duodenal mucosa or spots covering the edematous mucosa. So these are the appearances which can be met in a case with malabsorption, chronic diarrhea, and growth failure. Returning to our case, the upper GI endoscopy showed flat duodenal mucosa with no fissuring, no scalloping, no nodularity, or white membrane. During endoscopy, 3 duodenal biopsies, 1 from the duodenal bulb, were taken for histopathology. And the normal appearance of the duodenal biopsy in histopathology shows the villi and the crypts, and the normal height of the villi is 3 to 5 times the depth of the crypts, and this is a very important comment in the histopathologic examination of the duodenal biopsies. In celiac disease, there is infiltration of the epithelium with intraepithelial lymphocytes, moderate or total villus atrophy, crypt hyperplasia, and there is a classification for the celiac disease, which is called Marsh classification. The histopathologic examination of the duodenal biopsies in our patient showed moderate villus atrophy with crypt hyperplasia, and this may suggest celiac disease, but this was associated with infiltration of the epithelium with polymorph nuclear leukocytes and the scattered crypt abscesses, acute inflammation or acute duodenitis, and the heavy infiltration of the lamina propria with mononuclear cells, lymphocytes, plasma cells, and the eosinophils from 5 to 10 per high power field. This is chronic duodenitis, and these features are not specific for celiac disease. And few lymphoid aggregates were seen, which is not seen in celiac disease. So we were put in a dilemma. Is this case celiac disease, or this is an inflammatory condition of the GIT? Actually, we did not have celiac serology before doing the endoscopy because of the high cost. But after the histopathology, which was not conclusive, we decided to have celiac serology. We asked for anti-deamidated gliadin antibodies, IgG and IgA, which were negative. So this was not a case of celiac disease. We reviewed the causes of villus atrophy associated with crypt hyperplasia and significant inflammatory infiltration of the small intestine. And we found that the context of the case is fully matching with environmental enteropathy or environmental enteric dysfunction. Environmental enteropathy is a gut disorder that occurs among residents of low-income countries living in poor hygienic conditions. And it was first described among American adults returning from the low and middle-income countries in early 60s who presented with unexplained persistent weight loss. And actually, this pathology is very common in low-income countries, reaching 50%. Up to 95% of the children in Gambia showed evidence of environmental enteropathy. And environmental enteropathy has implicated as the predominant cause of undernutrition, accounting for 43% of undernutrition in income countries. And it is not limited to the growth, but it also affects the infantile cognitive development. What is the pathophysiology of the enteral environmental enteric dysfunction? The bad hygienic environment leads to chronic exposure to enteric pathogens, leading to chronic subclinical inflammation of the small intestine, and this causes two major events: structural changes in the form of villus atrophy and functional changes in the form of barrier disruption. The villus atrophy leads to loss of the enzymes for digestion, leading to maldigestion and malabsorption and malnutrition and growth retardation. The gut barrier dysfunction leads to translocation of pathogens and toxins from the gut lumen into the submucosa and reaching to the systemic circulation, leading to a state of chronic systemic inflammatory response, leading to the release of inflammatory mediators, tumor necrosis factor alpha, interleukin 6, which cause decrease in the release of the insulin-like growth factors and resistance to the growth hormone, and this leads to marked affection of growth, especially the linear growth. How to diagnose the environmental enteric dysfunction? There are a large battery of biomarkers for environmental enteric dysfunction, but the most common used is lactulose-mannitol ratio in the urine, which assess the integrity of the gut barrier. The patient is given a specified dose of lactulose and mannitol at the same time. The intact gut barrier will allow absorption of the small molecules of mannitol, which will be secreted in urine, but will not allow absorption of the large molecules of lactulose. If the gut barrier integrity is affected, a larger amount of lactulose will be absorbed to the systemic circulation and will be excreted in urine. And so the lactulose mannitol ratio will be increased in urine. This indicates loss of the gut barrier integrity. But this test is time consuming and very expensive. It needs urine sample from the patient every half an hour for 6 hours. The histopathology of the environmental enteric dysfunction shows many structural changes which are very similar to celiac disease. But recently, guidelines were done for the diagnosis of environmental enteric dysfunction, and a score for each of these 11 histopathologic findings were graded. The histopathology of the environmental enteric dysfunction is very similar to celiac disease, but there are some differentiating points. The villus atrophy and the cryptohyperplasia are more prominent in celiac disease, while the infiltration of the lamina propria with chronic inflammatory cells and the acute inflammatory cells is more marked in environmental enteric dysfunction, and the presence of lymphoid aggregates in the lamina propria is characteristic for the environmental enteric dysfunction. How to treat this pathology in the small intestine, which is very common, reaching up to 40% of children in low-income countries. We should target each point of the pathophysiology. The bad hygienic conditions should be corrected. The barrier function should be improved. Translocation of the pathogens leading to stimulation of the immune system should be suppressed. So we should use anti-inflammatory components. The gut repair should be increased, and the malabsorption should be treated by using pre-digested formula. And actually, if we revised the criteria given by Professor Ihab Khairi in the first presentation, we will find that all these components, all these steps will be given by the use of Peptide Junior, because it includes glutamine, which is very important for repair of the gut barrier. It is omega-3 fatty acids, which has an important anti-inflammatory effect. It has a balanced amino acid composition, which will lead to regeneration of the gut and supplying the gut with the essential amino acids, especially the aromatic amino acids and the sulfur-containing amino acids, which are very important for the gut repair. It includes pre-digested amino acids, pre-digested protein peptides, and medium-chain triglycerides, which are very easily absorbed. And take-home message: environmental enteric dysfunction is common among children living in areas with high pollution and poor sanitation. The environmental enteric dysfunction is a major cause of infant growth faltering, especially stunting, with impact on the child neurodevelopment and cognition. Environmental enteric dysfunction is usually asymptomatic, but may present with intermittent or persistent diarrhea. It should be suspected in malnourished children of low-income families not adequately responding to nutritional rehabilitation. The treatment of environmental enteric dysfunction should include easily digested, fully absorbed diets with supplements to improve barrier and the immune system function. And thank you.
أشكرك دكتور بروفيسور أحمد حمدي على البرزنتيشن ال very instructive. دكتور إيهاب اتفضل.
Thank you, Professor Ahmad, for this presentation, an excellent presentation and interesting presentation. And now we have question from our great professor, our mentor, Professor Dr. Hamid Al-Khayyat. Okay, he asks you about how to manage multiple food allergy And do you think elimination is the only solution? And what about food desensitization? Is it applicable in your clinic? 3 in 1, 3 questions. How to manage multiple
هو بيه
food
طبعا اولا الف شكر دكتور حامد بيه ان حضرتك موجود معانا، وده شرف ليا ان حضرتك تحضر التوك اللي انا قلتها. هو طبعا حضرتك المالتيبل فود الرجي هو بصراحه اوفر دايجنوزد عندنا، وفي حالات كتير قوي بتجي لنا دايجنوزد على انها مالتيبل فود الرجي، وبنبتدي نعمل ري انترودكشن للاليمينيتد فود ما بيحصلش رياكشن. لكن لو هي فعلا مالتيبل فود الرجي هيبقى المين لاين اوف تريتمنت لغايه دلوقتي حضرتك الاليمينيشن والسبلمنتيشن وذ هايبو الرجينيك فود، وفي الحاله دي هيبقى امينو اسيد بيزد فورمولا. حضرتك بالنسبه للديسنسيتايزيشن او الهايبوسنسيتايزيشن ثيرابي هي معموله علشان الاي جي اي ميدييتد فود الرجي، لكن معظم الحالات اللي احنا بنشوفها في الجاسترونترولوجي بتبقى نون اي جي اي ميدييتد، والنون اي جي اي ميدييتد فود الرجي مش بروفد في الافكت بتاع الديسنسيتايزيشن. فحضرتك لو هي مالتيبل فود الرجي هيبقى فعلا الاليمينيشن والسبلمنتيشن وذ امينو اسيد بيزد فورمولا، بس الطفل هيبقى كل فتره هيبقى ري اسيسد فور ناتشرال توليرانس، اللي هو كل 6 شهور او سنه ندخل الاكل اللي كان متشال.
Okay, I ask you about do you think elimination diet is the only solution or do you have other solutions?
وحضرتك الفود الرجي المين لاين اوف تريتمنت از اليمينيشن.
يس.
الحاجات الثانيه اللي البروبايوتكس والبريبايوتكس والدور بتاعها في انها تساعد شويه التوليرانس، بس هو حضرتك المين لاين اوف تريتمنت في كل الجايد لاينز بتاع الفود الرجي هو اليمينيشن اوف ذا انتيجينيك فود. الحاجات الثانيه حضرتك هتبقى اندر ترايل، والاورال ديسنسيتايزيشن لسه برضو اندر ترايل.
Okay, another question from Professor Hamid also. Do you think environmental enteric dysfunction easy to occur in children? Or it's common to occur. It's common to occur in children.
هو حسب حضرتك السوشيو ايكونوميك ستاندرد وانفايرمنت، عشان كده هي موصوفه في اللو انكم كانتريز كومن جدا.
Please Ahmed, there is a lot of requests. Please reply in English. They cannot understand Arabic. Okay? They want you to.
السؤال اصل حضرتك قلت لي السؤال بالعربي. طيب.
Okay.
Environmental enteric dysfunction. Environmental enteric dysfunction is very common in low-income and middle-income countries, but its problem in the diagnosis, it is asymptomatic. And now there is a big debate: is this asymptomatic or symptomatic? Because it presents with gross failure. It is very common in malnourished children in low-income and middle-income countries.
Okay, Dr. Ahmad Fuad asked you how to diagnose precisely the enteric environmental enteropathy, especially if histopathology may not be or cannot use histopathology. Cannot differentiate.
The biomarkers for the diagnosis of environmental enteric dysfunction till now is the proof of the disruption of the gut barrier. And there are many biomarkers for the disruption of the gut barrier. The most commonly used is lactulose mannitol ratio in urine, but it is very difficult technique, and I think it is not available in Egypt. So Ahmed, we will depend on the clinical diagnosis.
Okay.
A malnourished infant who has no symptoms or signs of an organic cause apart from intermittent attacks of diarrhea, and it is very important the environment, low socioeconomic standard, bad hygienic conditions. If so, we can either, it is very important to do celiac serology. Any child with intermittent or chronic diarrhea, you should first do celiac serology. If celiac serology is negative, you can start treatment.
Okay. He also asks you about how to suspect if the condition is asymptomatic. Can you suspect this problem or not?
Yes. In malnourished children, in low socioeconomic standards, not responding to the usual nutritional rehabilitation.
Okay.
Even in the absence of diarrhea, in malnourished children, not responding to the usual nutritional rehabilitation after 2 to 3 months.
Okay. Dr. Mustafa Al-Said. Welcome, Dr. Mustafa. We are happy that you are present with us. Dr. Mustafa Al-Said asked you, WHO advised zinc and vitamin A in cases of chronic diarrhea. Is it applicable in our country?
Thank you, great professor. Yes, it is advised, it is recommended to use zinc and vitamin A because both can help in regeneration of the epithelium of the intestine and improve the gut barrier integrity. Yes, okay. Yes, Professor, vitamin A and zinc are very important.
Okay, again, Professor Hamid asked you again, do you think the use of a medicine with enzymes of value in environmental enteropathy? Do you think that?
Use of digestive enzymes?
Yes, medicine with enzymes, yes.
I think use of pre-digested formula will be more beneficial than using the digestive enzymes.
Okay, Professor Ahmed, actually you have a lot of questions. Dr. Ahmed, Dr. Asma Magdi ask you about the treatment of environmental enteric dysfunction.
Okay, first, nutritional rehabilitation using a special formula, pre-digested formula, rich in glutamine, rich in branched chain amino acids, aromatic amino acids, omega-3. This is the nutritional rehabilitation. And we can add vitamin A and zinc. And now under trial, anti-inflammatory, including 5-amino salicylates and budesonide, but these are not proved yet, and the use of probiotics.
Okay. Dr. Aya asking you, what is the explanation of an elevated fecal calprotectin?
Because the continuous exposure to the enteric pathogens leads to inflammation. Inflammation, the intestine, leading to increased inflammatory mediators in the stools, including fecal calprotectin, and a state of chronic systemic inflammation. So the CRP may be mildly elevated.
Okay.
In the pathogenesis, we mentioned there is chronic inflammation of the small intestine.
Okay. Actually, we have a lot of questions, and so I'll take the last question. Would exclusive breastfeeding be beneficial in the prevention of environmental enteropathy?
Exclusive breastfeeding?
Yes.
Yes. Actually, environmental enteropathy is common after the age of 6 months, and exclusive breastfeeding delays the onset of the disease.
Okay. Thank you, Professor Ahmed. Actually, we have endless questions, but we are short of time, so I can shift now to, after thanking Professor Ahmed for his great, excellent presentation. Now we can shift to Professor Dr. Muhammad Hisham to present the last case today. Professor Dr. Muhammad. Dr. Muhammad, yes. Dr. Muhammad Hisham, you are welcome with us today. Dr. Muhammad is a representative of pediatric surgery department. Actually, there is a lot of cooperation between our department and the pediatric surgery department. You are welcome, Professor Muhammad, and we are waiting to hear from you. Okay.
Thank you so much, dear professors and colleagues. Thank you so much. I'm glad to be here in this scientific event. My name is Muhammad Hisham, Associate Professor of Pediatric Surgery. I'm going to talk about the relation between the proper nutrition and the surgical outcome. There has been some sort of an old myth about the surgical attitude towards post-operative care, assuming that the surgeon finished his duty towards his patient the time he takes off his gloves. Actually, caring of our surgery patient doesn't come to an end in the operating theater. Actually, it starts. The real concern of the surgeon is to deliver the patient to the safe side by acquiring proper wound healing and avoiding post-operative complications. So we are facing a race against the body ability to catch up to overcome the surgery-induced catabolic state of these patients. It is known that healthy children need regular nourishment for maintenance and growth, and the surgical patients need nourishment for optimal wound healing. So it is not always possible to meet the needs of pediatric surgical patients in this fashion and to combine both parameters at the same time. For sure, all my pediatric colleagues are very familiar with this schedule showing the pediatric caloric and protein requirements. This will be applied in the normal healthy child. But the question is, do we need an extra nutritional support in our surgical patients? Actually, with the exception of some cases of major burns and major intestinal surgeries and trauma, the pediatric surgical patient may not require more than the normal recommended amount of energy and proteins. This is a sign that we don't have to be overwhelmed about inducing more calories and more protein supplements to the patients post-operative. We depend on fulfilling the calculated daily and extra nutritional needs for the post-operative patients through one of the following routes, either enteral or parenteral routes. But for sure, we face many difficulties during this process. One of the famous obstacles we face are the TPN complications, like sepsis, liver affection, loss of IV access, and on the other hand, enteral feeding, although being more physiological and technically easier, still has its own complications like intolerance, feeding tube complications, and many other items. So how to overcome this? First of all, we recommend that securing a dependable IV access from the start is the procedure of choice, and not waiting for this choice to be an emergency, and not being done under stressful conditions when the patient loses the ability to catch up. Also, whenever you have the opportunity to shift from the TPN to the enteral feeding, you have to proceed and don't hesitate. And for sure, using of the nasogastric or even gastrostomy tubes for early feeding, like in some cases of nascent fundoplication treatment for GERD patients, especially if they are CP patients, don't think twice about inserting feeding gastrostomy during the operation. You have to insert it. It will going to support the patient nutritionally very well. And especially that the gastrostomy tube can be removed later on without any surgical intervention. So we're not going to lose anything. It's very useful indeed. I'm going to mention two examples of our post-operative cases upon which we applied the nutritional school. The first one is a 7 years old girl. Her name is Malak. Actually, Malak was a victim of dramatic scenario. She was suffering from abdominal pain, which was diagnosed somewhere of being of surgical pattern. Without digging into too much details about the surgeries, about the types of surgeries, all you have to know that she was operated 4 times in about 3 months. She was diagnosed at the first as being acute appendicitis. The appendix was removed. Then continuation of the abdominal pain, they saw that maybe it's cholecystitis, so they have to remove the gallbladder. Then she suffered from real adhesions causing some obstructions. So she was explored for the 3rd time for adhesolysis. Then one of the loops suffered from blood supply shortage, so they have to explore for the 4th time to undergo resection and anastomosis. Actually, after digging into her investigations and her radiological documents, we found that the final diagnosis wasn't any of this. It was actually acute pancreatitis, something which could have been managed with conservative treatment without any surgical intervention. When the patient presented to our institute in Ain Shams University, her weight was 19 kilograms. In a case of severe malnutrition, that she was unable to move. She was bedridden. She wasn't tolerating enteral feeding and in a very bad psychological state. We started our urgent plan by giving her IV support through TPN and IV proton pump inhibitors for a couple of days, after which nasogastric tube was inserted and we started peptide-based formula, Peptamin. The challenge here was how to start oral feeding for severely traumatized intestinal mucosa due to the repeated surgical intervention. So our choice was peptide-based formula, and we started at the rate of 20 kilocalorie per day, kilocalorie per kg per day, and we started to increase gradually the caloric requirement for the patient. Our plan was starting through the NG tube for 48 hours. And if she is tolerating, we would start oral feeding. And if not, we planned at that time for inserting gastrostomy to avoid the long-term drawbacks of nasogastric tube. We started with exclusive formula. We had to stress on this choice to avoid the possibility of intolerance to other types of food. Because we are trying to avoid possible distension, which will be our first enemy to her bad wounds, which we were dealing with by that time. After 2 weeks of admission, the response was satisfactory, and she started to show signs of catch-up. This is a picture of our patient, maybe 3 weeks after starting of the supportive nutritional treatment. 2 months later, we had very good results. Her weight was almost reaching 30 kilograms with a weight gain of 10 kilograms in 2 months, and better wound status and much improvement of her general well-being and her psychological condition. The second example is for 3 years old patient. Ruaya was suffering from something unique, was magnetic particles ingestion. And the problem was that she ingested more than one particle. And for those who didn't experience such case, it is a nightmare for surgeons because the magnet parts try to search for each others and adhere together, causing intestinal amalgamation and picture of intestinal obstruction. She was presented with very, very low serum albumin, elevated sepsis parameters, and levels, and signs of intraperitoneal inflammation. When we explored her, we found that there are ileoileal fistulas, which happen due to the long-standing amalgamation between the intestinal loops when they adhere to each other through the magnet particles, and long segment ileal loop has to be resected with primary anastomosis. And the challenge here was doing the surgical repair in one session. We did maybe about 3 anastomosis, and the surgical repair in one session is something very difficult and induce a large amount of tissue trauma, which cause a lot of drawbacks after the surgery. Our plan for her post-operative nutrition support was raising the serum albumin and glutamine at the same time to promote the healing of both the wound of the patient and the intestinal anastomosis to avoid the possibility of any leak, which will push us for another exploration. And on the other arm, we started peptide-based formula for the injured mucosa and to avoid the drawbacks of delayed nutrition. Feeding started on day 4 post-operative, and she was discharged on day 6, which is a very, very good result, and started to gain weight again 2 weeks after the surgery. We want to say that we are not dealing with small adults bodies, but we are dealing with totally unique physiological pattern which needs special care, and this is what we are trying to promote in our patients. Thank you so much.
Thank you, Professor Muhammad, for this, Muhammad Hisham, for this nice presentation. I would like to start the discussion with you. Are you ready, Professor Muhammad?
Sure.
Okay. Professor Dr. Hamid Al-Khayyat asking you, what is the diagnostic tool to confirm acute pancreatitis and its management?
Okay, we depend now on the radiological modalities. We depend on the CT scan with the double contrast oral and IV. At the same time, the levels of the calcium, and the ultrasound will show also the presence of bulky pancreas. Regarding the management, it's totally conservative with IV fluids and MPO. Sometimes we may be pushed to interfere if we are suspecting that there is necrotic parts from the pancreas which may need debridement, and this appears if the patient is not showing any response to the medical treatment, or the trusted radiological results is saying that there is a part which is devoid of its blood supply.
Okay, can you summarize to us what are the surgical cases that you need Peptamen Junior to use in this case, in these conditions? Okay, and what's your experience with Peptamen Junior in different surgical conditions?
Actually, Peptamen Junior, regarding our experience, it allowed us to start early feeding. Yes. Because we have been practicing the old school of waiting 4 days after the surgery before starting any oral feeding. Now we are trying to start I don't say the ERAS, the early recovery after surgery, but at least we are trying to save 1 or couple of days for the patients to be staying in the hospital. So we try to start maybe at day 2 or day 3 at most after the surgery. I can get use of the Peptamen in 2 things. The first, as I said, is the early feeding, and the second is avoiding the distension, because as I said in my presentation, the abdominal distension is our enemy. The distension means burst abdomen, because it will get a very strong tensile strength on my sutures, which are very fresh, so it may cause burst abdomen. My experience of Peptamen Junior with the surgeons is mainly the intestinal surgeons. Because I think that it's very important in maintaining a good mucosal creeping cells.
Functional integrity and structural integrity.
Yeah, so it improves the anastomosis very, very good, in a very good way.
Okay. Okay, thank you, Professor.
I have a question, Dr. Ihab, for Dr. Mohammed Hisham.
Sure.
Can I tell something before this question?
Yes,
okay.
Yes, sure.
It's a great honor to me to welcome our great professor, Dr. Sana Youssef. She is with us and she sent a message. She said that congratulations to all super excellent speakers and big thanks to Nestle Health team for such an elite event. Thank you very much, Professor Dr. Sana, for being with us. It's a great honor for me and for all speakers to that you are with us today. Okay. Okay,
thank you, Dr. Ihab. Thanks, Professor Sana, for your presence. Really a great honor, as Dr. Ihab mentioned. I have a question for Professor Mohammed Hisham about your experience with the usage of Peptamen Junior in post-bariatric surgeries like sleeve or bypass.
Okay.
Okay. A good question.
Yeah. In our cases, procedures, all of them, 13 of them were gastric sleeve, and maybe 2 or 3 cases of gastric balloons. So far, we are not trying to make any bypass because it's not justified in children so far. Anyways, in all the cases, we start the Peptamen Junior after the operation. We started day 1 after the operation, actually. Because somehow we are getting more trouble for the anastomosis, which is done laparoscopically using the staplers. The anastomosis is very vascular, so we are more trusting it regarding its blood supply. So we start on day 1. Actually, it is very important to give the patient the sensation that he's starting feeding one day after the operation. It improves his well-being and his psychological status, and also as we said, it prevents the distension and the feeding intolerance, because the patient of the gastric sleeve gastrectomy is suffering from the diminished volume of the stomach itself is a very obstacle towards starting his feeding. So giving him small feeds exclusively by Peptamen Junior is a very good plan for giving him the total caloric requirements in very small feeds and tolerable formula like Peptamen Junior.
Okay. Thank you,
Very
Professor
nice,
Muhammad Hisham.
Professor Muhammad.
Thank you so much.
I have another question. I have another question regarding surgery. I think it's a new era or new subspecialty, and you have a very well appreciated role in Ain Shams University with your staff in nutrition support with cooperation with nutrition team.
Yes.
The second question is, what is the most compatible tube with your experience, the most compatible with the using of Peptamen Junior? You mentioned you have PEG, you have any other tubes, nasogastric, nasojejunum. So please share with us your experience, Professor Muhammad.
Thank you for the question. Actually, it's a very important question because one of the important advantages of Peptamen Junior is that is going to give us the courage to make more jejunostomy tubes, because the jejunostomy tubes has a very important reputation that the feeding tolerance will be a very obstacle after the operation, because we introduce the feeding directly into the jejunum after bypassing the reservoir of the stomach and the absorptive tube, the duodenum. So the dumping syndrome was very common, and the hypermotility of the intestine after giving any formula through the jejunum. So now the jejunostomy tube after insertion will be of more value after introducing, after using the Peptamen Junior, because as we said, it's much more tolerable by the injured mucosa. So I think that my answer would be the jejunostomy tube.
Jejunostomy.
Okay. Any other questions, Dr. Samuel?
Thanks, Dr. Ihab.
Okay. Now
I have something to share. Lastly, Dr. Ihab, بعد إذنك.
Okay.
Please, Hassan, give me the share screen.
Okay.
At last, I only will share a sum up of. I would like first to thank all of professors for their great input and their great experience in Ain Shams University, the Demirdash University, for years. We have been cooperating, and we reached a lot of success stories with the true cases you just presented right now. And I think there is much more in another units. We have a lot of success stories in another units and with another professors in Ain Shams or in another universities across Egypt, from Upper Egypt, from Alex, from Delta. We have the same success stories and will be displayed and presented soon and shared with you in the coming events. Also, I will only share a sum up for the indications we talked about today and another indications for Peptamen Junior and its reconstitution. So give me just 1 minute. Okay, I will share my screen now. Do you see my screen? Okay, we will sum up. We will sum up now the cases we have shared. Sorry. These are the clinical applications of Peptamen Junior. As you see, it's a map for the usage of Peptamen Junior in the standard formulation, as we saw different cases right now with our dear professors. And in high caloric, as you know, Peptamen Junior is very eligible for reconstitution as a standard formulation 1.0 kilocalorie per milli, isocaloric formulation, or high caloric 1.5 and more up to 2 kilocalorie per milli, according to the case and the volume restriction we have in some cases. So for the short term, as you see, acute malabsorption, GERD, early enteral feeding or transition from TPN, and intolerance to whole protein feeds, and we have to move to high caloric formulation, as we saw in some cases like ICU, trauma, burn, sepsis. They need higher demand than normal patient. Pancreatitis, volume restricted, we have to increase concentration, and we'll see in the next slide how to reconstitute Peptamen Junior. In long-term plan, we can use Peptamen Junior in complications in cancer therapies or neurological impaired patient, Crohn's disease, cystic fibrosis, HIV, or immunocompromised patient, short bowel, chronic malabsorption, and as you see here, cystic fibrosis and cerebral palsy are some of the cases which have some difficulties in tolerance, and we have to reconstitute it in condensed form. This is a table is very important. This table is very important for as a take-home message for how to prepare Peptamen Junior. If we want to prepare it first as a high caloric 1.0 isocaloric formulation, you will see we'll have 210 millis of water, and we will add 7 scoops of Peptamen Junior. Then this osmolarity is 260 millismol per liter, and this having 250 milli total volume of a meal with isocaloric. This means that it has 250 milli in 250 kilocalorie. If we want more calories to have it more condensed, we can make it 1.25 kilocalorie per milli. Then we will add 9 scoops to 200 milli. And this will have osmolarity of 350 millismol per liter and the calories of 1.25 kilocalorie per milli. If we want to have 1.5 kilocalorie per milli of a total calories of 375 kilocalorie per meal, we will add 11 scoop instead of 9 scoop to 190 millis of water with osmolarity of 433 millismol per liter. And if we want it as a 2.0 or doubling the calories in the same volume, all of these are in the same volume of 250 millis total volume per meal, we can add 190 millis water to 14 scoops of Peptamen Junior, which always have the lowest osmolarity, as you see, even in high concentration, and it will be very beneficial to volume restricted patients. This is all I have to present for you as a take-home message for you, dear professors and doctors. Really, we were very glad to have this scientific and enriched content for sharing experience of Ain Shams University. I'm sure next waves we will share success stories from different universities and different units as well. I thank everyone contributed to this event, our dear professors with their input, our colleagues with their invitations, and the CCG partner for organizing this well-deserved event. Thank you all. If anyone having any other question, please raise a flag. Do you hear me?
Yes, we hear you, someone.
Thank you, Dr. Ihab. Thanks, Dr. Omneya. Thanks, Dr. Mustafa Hodhod. Thanks, Dr. Yasmin Gamal. Thanks, Dr. Iman Fouda, Dr. Hanan Ibrahim, Dr. Ahmed Hamdi, Dr. Muhammad Hisham. Really, your input was very great today. And I will leave the floor for Dr. Ihab Khairi.
Thank you, Samuel, and thank you all of you, Nestle Health Science team, Dr. Ahmed Faltas, Dr. Sarah, Dr. Samuel, and thank you all my colleagues, Dr. Omneya Rashidi, Dr. Hanan Ibrahim, Dr. Iman Fouda, Dr. Ahmed Hamdi, Dr. Muhammad Hisham, and our moderator, Dr. Yasmin Gamal, and our Head of Pediatric Department, Professor Dr. Mustafa Al-Hudhud. Thank for all attendees for being with us all this time. And we hope that this webinar was a fruitful one. And thank you again for all of you. And we hope to see you again. Good luck.
شكرا دكتور إيهاب.
شكرا يا صامر.
شكرا لك.
السلام عليكم.
وعليكم السلام. تفضلوا.